My name is Mike Colvard, and I'd like to welcome you to this video supplement of Achieving Excellence in Cataract Surgery. Our goal is to help you to become a better cataract surgeon by breaking down the fundamental aspects of the procedure into steps that are both easily understandable and reproducible. To do this, we've enlisted the help of some of the world's finest eye surgeons, each one of whom is either the originator or one of the earliest proponents of the techniques that they'll be discussing in this video. And I'd like to take this opportunity to thank, in order of their appearance, Dr. Howard Gimbel, Howard Fine, David Chang, Mark Packer, Patrick Riedel, and Richard Hoffman for the fantastic job that they've done in putting this video together. I'd also like to congratulate you for all the hard work that you've done to get where you are today, and to thank you in advance for all that I know that you'll do for ophthalmology. Because of course you are the future of ophthalmology. Continue to work hard, learn everything there is to know today, and then move it forward and make us better. Take care of yourself as well as your patients. Best wishes to you, and thanks. For the corneal incision, I like to begin the procedure by stabilizing the globe with a ring holder. And then we begin at the limbal arcade with a blade that's selected which is precisely matched to the width of the phaco device. This position gives you the strongest, the most structurally sound clear corneal incision. So you begin at the arcade and then drop your wrist and then direct the blade anteriorly through the stroma of the cornea to a length that is equal to the width of your blade. And then you raise your wrist, follow the plane of the iris, parallel to the iris now enter the anterior chamber, and this should give you an incision that is square. That is to say, the incision is as long interstromally as it is wide. This gives you a very strong, structurally sound incision. Then at the conclusion of the procedure, you want to irrigate the side port. I use a bimanual INA system, so there are two side ports. And then you hydrate the primary incision. Now, if you've constructed a very sound, square incision, this should be absolutely watertight. And you need to challenge the incision rigorously. If the incision is not properly constructed, or for any reason it leaks with pressure, you should just put a suture in the incision. I like to use scleral incisions, especially if I'm operating superiorly. This comes in handy if you like to operate on the steep axis. And you can do a scleral incision even under topical anesthesia, but it's helpful if you just create a little bleb conjunctivally with 2% xylocaine, and this gives you really good anesthesia of the sclera. Then you'd like to make your peritomy, and ideally you want to get under tenons, of course, so that you can get right to bare sclera in the first pass. This doesn't always happen, but the more you do it, the more often you are able to get to sclera on the first pass. And then you create a peritomy that's roughly equal to your incision. You want to cauterize lightly. Too much cauterization can result in some scleral shrinkage and induce astigmatism, and also it can make your incision gape as well. Now the incision should be placed 1 or 2 millimeters posterior to the limbus, and you got to be careful not to make this groove too wide. If you make it too wide and you dissect into clear cornea wider than your keratome, your incision then can leak during the case and you can lose chamber. We then use a crescent blade carried into clear cornea. You want to go at least another 1.5 millimeters into clear cornea You check that carefully, and then use your keratome to actually enter the anterior chamber. So you follow the same track that you've made, and again you tilt the blade so that you're parallel to the plane of the iris and enter the anterior chamber. This should give you a rock-solid incision. Once again, the incision should be at least as long as the width of the incision.
I'm Howard Gimbel, and it's a pleasure to share with you some video clips on anterior capsulorhexis, CCC, and posterior continuous curvilinear capsulorhexis, PCCC. I think that the globe should always be fixed with the second hand. It can be done with forceps, as illustrated here, or with a fine Thornton ring. My preference is to puncture the capsule with the capsulorhexis forceps, and then carry it in a counterclockwise direction, but what direction and where to start is entirely surgeon preference. This next clip shows the eye fixed with a fine Thornton ring. You can see the puncture with the capsulorhexis forceps. A little push ahead creates a triangle with the vertical tear in the capsule. It's easily grasped with the capsulorhexis forceps. A radial tear perpendicular to the incision can be hard to grasp the edge of the capsulorhexis. It's important to size so that optic capture, or rhexis fixation, as Tobias Neuhan termed it, can be utilized if necessary, if the posterior capsule is compromised. Rather than puncturing with the forceps, a sharp cystotome is necessary in younger children, or in children in general, and in younger adults, where the zonules are loose or traumatized because there's no tension on the capsule, and the capsule can be tough in traumatic cases. So this is a traumatic cataract in an 11-year-old, a very cooperative child that we are doing under topical anesthesia. So you can see we're holding the eye with the second hand. And taking the tear very cautiously. Because the zonules are more elastic, the capsule is more elastic, and one has to stop and inspect to see where the tear is progressing, relieving the tension because the capsule can be pulled centrally and the tear be going out farther than expected or visualized. So much more deliberate, cautious approach in a child and a young person. Trypan Vision Blue is a real asset for the white cataract. The viscoelastic I prefer in this type of cataract in young people, and for me in general is Helon 5 or Helon GV, a very cohesive viscoelastic, because it has the most pressure effect to flatten the capsule, to avoid radializing tears when puncturing the capsule and when taking the tear around the circumference. You can see that with that viscoelastic, the trypan blue can be just smeared onto the capsule under the Helon without staining the cornea. And I usually aspirate a little bit, which was edited out here, and then add more viscoelastic before starting the capsulorhexis to make sure that there's good pressure to flatten the capsule and keep the contents, if liquid, in the capsule, to not allow it to obscure the view when continuing the tear. So with the proper viscoelastic, one can achieve a successful CCC even in a very intumescent liquid cataract. The same techniques for anterior capsulorhexis can be applied to the posterior capsule. Here you see the completion of a child PCCC done purposely to use optic capture and avoid secondary pacification of the visual axis. But here's a young adult with a posterior capsular fibrotic plaque. This could be left and yagged later, but also it can be removed with PCCC technique. You saw that after the initial puncture, the Helon is put through the small opening to protect the vitreous face, while the PCCC is continued and completed, so that the vitreous is undisturbed, whereas a YAG capsulotomy would disturb it. So anterior and PCCC are essential and allow capsule fixation.
Hydrodissection was first described by Faust and later by Hirschman as a method of mobilizing the lens within the capsular bag. It essentially utilized an injection of fluid through the soft cortical layer of the lens, which then allowed for the nucleus and epinucleus to be rotated. At the time that I was doing phacoemulsification and utilizing hydrodissection, I became aware that the most common way for me to rupture capsules during phacoemulsification surgery was during the cortical cleanup portion of the surgery. And so I became very motivated to find a way of removing the capsular cortical connections during hydrodissection. The technique involves tenting up of the anterior capsule with a 26 gauge cannula that has the bend close to the hub rather than close to the tip. And then by injecting carefully with continuous pressure a fluid stream under the capsule, peripheral to the cortex, in such a way that the fluid went around the cortical layer of the lens, filled the posterior capsule, and came up to the equatorial region of the lens, where it was stopped by the capsular cortical connections. If one continues to irrigate fluid at that point, the lens will be subluxed or hydro-expressed out of the capsular bag. However, if as the fluid becomes loculated in the posterior capsule and reaches the equator, the lens starts to move forward and the capsulorhexis appears to enlarge. At that point, if one takes the needle and presses the lens posteriorly toward the optic nerve, the fluid will be forced circumferentially around the equator of the capsule and flow out of the capsulorhexis. It will rupture the capsular cortical connections in the equator of the capsule as it comes around and flows out of the capsulorhexis. What one sees immediately is a return to the original size smaller size of the capsular rhexis, and radial striations as cortical fibers are washed centrally. I usually repeat this in at least an additional distal quadrant so that I have done cortical cleaving hydrodissection fluid waves in both distal quadrants, and then I will attempt to rotate the lens to document that indeed I have completed my hydrodissection appropriately. At that point, I will perform hydrodelineation. I do that by moving midway between the center of the lens and the edge of the capsular rhexis, aiming toward the central plate of the lens, and as the lens starts to move, I am aware that I'm at the junction between the soft epinucleus and the more firm endonucleus. At that point, I turn the cannula parallel to the harder endonucleus and do a backward and forward to and fro maneuver to create a tunnel at the outer edge of the anterior surface of the endonucleus. I then back the cannula out, leaving about 1 millimeter of space before I inject, so I am injecting into a relatively empty space, and the fluid coming out of the cannula will find the path of least resistance, which is always the junction between the endonucleus and the epinucleus. I will then repeat that in the second or third quadrant. Usually in a soft lens, one will immediately see a golden ring. In a firmer lens, one might not see a golden ring because the separation of these two layers is more peripheral and may be hid by the iris. However, sometimes one will see an arc, a dark arc, and one can then repeat those injections at one or the other edge of the arc until circumferentially there has been a contiguous circle of hydrodelineation demonstrating completion of the separation of the epinucleus from the endonucleus. I then usually rock the nuclear complex to further separate endonuclear-epinuclear connections and then proceed with the phacoemulsification. Once endolenticular phacoemulsification has been completed, the epinucleus is removed, and for me, I usually remove it by aspirating the roof and rim of the distal quadrant in foot position 2, pulling it centrally, and then as I go into foot position 3 and mobilize that roof and rim of the epinuclear shell, mini surges take place, which are associated with a washing around the floor of the epinucleus of the cortex within that quadrant. I do that in 3 quadrants, and I use the 4th quadrant of epinuclear roof and rim as a handle. I engage it in foot position 2, pull it centrally, while at the same time with my second handpiece, push the floor of the epinucleus away from the incision in such a way as to flip the epinucleus, remove it from its proximity to the posterior capsule, and then aspirate it or remove it with very low powers of phacoemulsification. In about 70% of cases, there is no cortex left after trimming and flipping the epinuclear shell. For those 25 to 30% of cases in which there is cortex remaining, I will do one of several things. The most common method, if there's a lot of cortex, is to inject viscoat through the floor of the cortical envelope, and this will result in a spread of the viscoat laterally and vertically upward in such a way as to drape the floor of the cortical envelope on top of the capsule. One can then implant the IOL. The cortex will drape on top of the optic of the IOL, where it can easily be mobilized along with residual viscoelastic. This adds incredible safety to cortical cleanup because it's almost impossible to rupture the posterior capsule when the cortex is on top of the optic. If I have just a quadrant, I may just remove that with an INA handpiece. And frequently, if there are just a few wispy strands of cortex, I will implant the IOL and just go after them as I go around removing the residual viscoelastic. The wispy strands are much thinner than cortex that is removed in the usual manner, and as a result I use a 0.2 millimeter opening in my aspiration handpiece. This is a technique that I first published in 1991, and you will see in some of the following footage the use of scleral tunnel incisions rather than clear corneal incisions, because I was using this technique at the time I was still doing scleral tunnel incisions and before I had described clear corneal incisions. This has been an enormous advantage for me in terms of dramatically reducing the incidence of posterior capsule rupture during phacoemulsification. I hope it turns out to be an advantage for you as well. The anterior capsule is elevated and gentle irrigation sends a posterior fluid wave that ruptures posterior capsular cortical connections. The lens bulges and is decompressed, rupturing equatorial and anterior capsular cortical connections. A second fluid wave is sent posteriorly in the opposite quadrant, and once again the bag is decompressed. The same 26-gauge blunt cannula is used for hydrodelineation, dividing the nucleus circumferentially into a central, more compact nuclear mass surrounded by a soft epinuclear shell. Following endolenticular phacoemulsification of the central harder portion of the nucleus, the residual epinuclear shell is flipped upside down and aspirated, with most of the cortex attached to the epinuclear bowl. In this case, we can see that once the epinucleus is removed, the bag is clean of cortex except for the quadrant to the right. The cortical connections in that quadrant have been loosened. The posterior capsule will now be polished, and viscoat will be utilized to drape the cortex over the anterior capsular flap, and then to deepen the capsular bag for lens implantation. The residual cortex will be removed with residual viscoelastic under the protection of the posterior chamber implant. In a second case, we send a fluid wave posteriorly, resulting once again in bulging of the lens within the capsular bag. This is decompressed, after which a second cortical cleaving hydrodissection injection is done in the opposite inferior quadrant, and once again the bag is decompressed. The same cannula is used to perform hydrodelineation, which in this case results in a striking golden ring. After removing the central hard portion of the nucleus, the epinuclear shell is flipped and removed, and in this case we see that the bag is totally clear of any residual cortex.
After we've made our incisions, we begin the capsulorhexis. The ideal capsulorhexis is about 5 millimeters in diameter. This will cover the edges of the intraocular lens and help prevent capsular opacification. If you make the capsulorhexis smaller than this, it's really hard for you to get to the nucleus to mobilize the quadrants during phacoemulsification with divide and conquer. And if you make it much wider, you begin to have more difficulty controlling the capsulorhexis, and it's easier to lose the rhexis and create a posterior tear. Next, we perform hydrodissection. And with hydrodissection, we really create this cortical cleavage that allows you to move the nucleus. You place fluid that lifts the nucleus slightly, then you tap this down, and this frees the nucleus so that during the case you can place very little stress on the zonules. Now this is an important thing to do, particularly beginning. I'd like for you to place a little viscoelastic in the anterior chamber, and then using your chopper, check to be sure that the nucleus is spinning freely. Taking that extra moment to do that ensures that you will not be placing a lot of stress on the zonules. If the lens doesn't move freely, then go ahead and continue your hydrodissection. Then, using moderate flow, low power, and low vacuum, begin sculpting the grooves. Low vacuum will allow you to create the grooves without engaging or grabbing the nucleus. You start the groove at the proximal margin of the capsulorhexis and carry the groove across the distal margin. Use the phaco power only as you sculpt forward. This will reduce the phaco time and help to limit the phaco energy released in the anterior chamber. Carry this groove posteriorly until you see a good fundus reflex. As a rule, the depth of the groove should be about 3 times the width of the phaco tip. You then rotate the nucleus 90 degrees and repeat the same groove starting proximally at the edge of the capsular rhexis and then distally to the distal edge of the capsular rhexis. And what you're doing, of course, is creating essentially a cross or an X which divides the nucleus into quadrants. When you make these grooves, be sure to carry the groove all the way across the central part of the X so that you don't leave a big mound of nuclear material right in the center. This makes cracking the nucleus more difficult. Now the cracking procedure. Put the instruments at the very bottom of the groove and lift up a little bit, and this creates a nice radial crack in the nucleus. So at the very bottom, spread and lift. If you place the instruments too shallow, the crack will not occur. You'll tend to compress the bottom of the nucleus. Now you switch your device to Phaco 2, which has higher vacuum, higher flow. But one of the beauties of divide and conquer is that you don't have to use very high vacuums in order to bring the nucleus forward in most instances. And then you take each quadrant out, and you see you have very good stability of the anterior chamber. And you can work in the iris plane. This is not only a very safe technique, but it's also one that's very kind to the corneal endothelium. Now at the end of the case, as you start to emulsify the very last quadrant, I like to switch to Phaco 3, and in Phaco 3 is basically the epinucleus setting, but it's also a setting where there is less vacuum. There usually is good flow, but less vacuum, and things are just a little bit better controlled at the very end of the case, and this helps you to maintain the chamber at that time when you have very little protection of the posterior capsule. Next, of course, you remove the cortex. I prefer a bimanual technique because it helps me to remove the subincisional cortex. So we have the irrigation on the left and aspiration on the right. These incisions can be made with an MVR blade so that they're very consistent, they absolutely don't leak, and it's a simple thing to put one extra side port in. These side ports, if they're well constructed, never leak. Then we switch hands, we irrigate now from the right and aspirate from the left. And you have excellent control and visualization of the anterior chamber using this bimanual technique. And as you see, the removal of subincisional cortex is really not an issue at all. You then can use your irrigation or aspiration to polish the posterior capsule.
This is David Chang with a video demonstrating the horizontal phaco chop technique. I like to initiate the capsular rhexis in the center, first incising a C. This creates a little flap that you can automatically fold over on its side, in this case with a bent 25 gauge needle, which is serving as my irrigating cystotome. We want to avoid digging into the anterior cortex and epinucleus too much, because this will only make it hard to see the edge of the capsular rhexis. The hydrodissection is important because this is going to cleave off the epinucleus from the capsule, and then hydrodelineation will cleave off the epinucleus from the endonucleus. So we hook the capsular edge. There's the first hydrodissection wave, followed by the very rapid hydrodelineation wave, which you don't really see develop. Now the first thing we do is we remove the anterior epinucleus. We're going to introduce the horizontal chopper at about 45 degrees away. We hook the equator We then impale the center of the nucleus, and then the chopper is brought directly toward the phaco tip to break the nucleus completely in half. You then repeat this, and with a soft nucleus like this, we don't have to chop it into too many pieces. The horizontal chopper is ideal because it can hook the equator of the nucleus. It's sitting within the capsular bag, and it's actually occupying the potential space that is formed by the epinucleus. We then try to aspirate what remains. We go under the capsule, we hook the equator, divide the remaining fragment, and then we try to aspirate these pieces and bring them forward. Horizontal chop is the preferred technique for the softer nucleus such as this. It's difficult to shear this with the vertical chopping motion, and in this case I'm mostly trimming the epinucleus and the remaining small fragments of endonucleus. Then we'll flip the epinuclear shell, and this is where good hydrodissection is key, because if we can mobilize the epinucleus, we'll have no trouble flipping it. We're doing the last little bit of removal in the safe area that's in the middle of the pupil, at the pupillary plane, and now we're just removing the cortex. And so this is a supracapsular technique in that we're dividing the nucleus into small fragments, and then we do the ultrasound-assisted phacoaspiration at a safe distance from the posterior capsule and the endothelium in the central pupillary plane. This is a Graether collar button that is sandblasted on the bottom. The foldable three-piece Clariflex IOL through the injector. I like to go bevel up, and then this allows me to push backward, pushing the globe into the orbit when I encounter resistance, keeps the globe from moving, and establishes counter traction for introducing the injector system. This way you don't have to pull on the corneal lip with the forceps. And then we can see the rhexis overlapping the optic and the sharp edge of the Clariflex optic. This is a case of vertical chop with a dense nucleus, in which we're going to use one of the new media features of the AMO signature to display only the vacuum. That'll be the blue graph in the lower left. We start with high vacuum and burst mode. We've set it at 550, and you can see that the vacuum climbs here and then drops after we break occlusion. Again, the idea is to maximize our purchase. This is a shearing force that creates the vertical chop, and we want to have a locked-on grip with our high vacuum that you can also see helps me to pry these pieces apart. I'm less concerned about surge at this point because we have the entire nucleus filling the capsular bag, and you can see that this is still a very stable chamber. This is an entirely unedited video section here of the chopping, so that you can see every little moment of chamber instability. Nothing has been edited out. But more importantly, you can see the live graphs going on showing that we're consistently reaching above 500 in our vacuum. Now we're going to switch, once we get the pieces out, to variable white star and a vacuum now that's lowered to 450. But we have the anti-surge algorithm, which is called CASE, and that is where you'll see in the blue graph these striated bars. And at that point, what's happening is the machine is automatically lowering your vacuum, and I've asked it to lower it from 450 to 400 millimeters of vacuum so that we're breaking occlusion consistently from a lower level of vacuum. And there you see in this graph again, it goes up to 450, then it drops to 400. And I call this an anti-surge algorithm. It's like the ABS system for your car's brakes. The machine will take over and do something that enhances safety. You can turn it off if you want. But you can see that I wanted that high vacuum to occlude. Now watch here, I'm going to occlude, I'm going to lift this piece and lock onto it, and then you see the striated bars showing where the case or anti-surge algorithm is coming into play. And then I'm finally going to switch to a lower vacuum level right here as we get to the last pieces. And now my maximum is at 250 because this is the epinuclear setting. And you'll see me get that little thin shell of epinucleus in a moment. Once again, this is the advantage of a micro phaco tip, is like a smaller INA tip. It's a little bit safer for occluding with the epinucleus.
This is a case of moderately dense nuclear sclerosis, which we are going to address with a bimanual microincision technique. To employ this technique, we fixate the eye with a modified fine Thornton ring and then make 2 paracentesis-type incisions with this trapezoidal diamond knife. The internal opening of this incision is 1.2 millimeters and the external opening is 1.3 millimeters. This is exactly the right size to facilitate introduction of 20-gauge instrumentation. It's always important to suit the incision size to the gauge of instrumentation, whether that's 19, 20, or 21 gauge. This can simply be determined by noting the outer diameter of the instrumentation for each gauge size and then applying the 2 pi r conversion to find the diameter. Here we are initiating and continuing the capsulorhexis with a pinch action microincision capsulorhexis forceps. There are several advantages to utilizing this type of forceps. The first is that by introducing them through a microincision, there is no chance for egress of viscoelastic during completion of the capsulorhexis. This allows us to custom tailor the size of the capsulorhexis to the size of our implant. In general, we would like the capsulorhexis to be slightly smaller than the diameter of the implant we are going to use. The reason for this is to facilitate a shrink wrap effect around the implant to induce a capsular bend and help to inhibit posterior capsular opacification. The importance of a capsulorhexis smaller than the lens optic and the shrink wrap effect has been well documented by David Apple and the researches he has done on postmortem cadaver eyes. The other thing about using a pinch action type forceps is that in initiating the capsulorhexis, there are no unopposed forces on the capsule. So in cases of weakened zonules, such as pseudoexfoliation, there is no chance of causing further zonular damage because all the forces on the capsule are equal and opposite. And here you can see that we get a nice centered capsulorhexis of precisely the size we want. We can also remove the anterior capsule through that incision. Hydrodissection and hydrodelineation can be carried out with this technique in exactly the same way that they are carried out with standard coaxial phaco. At first, in employing a bimanual microincision technique, there was concern that inordinate rise of pressure in the anterior chamber could blow out the posterior capsule during hydrodissection. However, it appears that there is, in fact, adequate egress of viscoelastic during this technique. The only exception to this rule would be in using a super viscous viscoelastic with a very low zero shear viscosity, such as Helon 5, which will not egress through these small incisions and could cause a sudden rise in pressure. In that case, it's important to have a fluid channel constructed through the Helon 5, which allows egress of the balanced salt solution to the incision. Now I've introduced in the left hand an irrigating chopper, which is nicknamed the penguin chopper, and that's going to be used in this rather dense nucleus. I'm going to impale the nucleus after cleaning off the cortex and epinucleus on the center here. I'm going to impale with my phaco needle, and you'll see I use high vacuum and moderate amounts of ultrasound energy to get a firm hold on the endonucleus. Once I achieve a high vacuum here, I will back off into foot position 2, and you'll see the power drop to 0, the vacuum remain high, and a nice split of the nucleus. And you can see there I've got about a 50-50 split of the nucleus, which is exactly what I wanted to occur. Now I can use that penguin chopper to rotate the nucleus into the position I want, and now attack the distal heminucleus, again by impaling it with moderate ultrasound power and high vacuum, and then again utilizing my chopper to break off a small segment. And there you can see I've got 1/6 of the total nucleus, or 1/3 of that 1/2. The size of the segments is determined by the density of the cataract. The denser the cataract, the smaller the pieces that you want to break off, because you will be able to consume these pieces with minimum amounts of ultrasound and high vacuum if they are of the right size. Too large a piece will fragment in the anterior chamber and require multiple episodes of chasing down to get it all into the phaconeedle. And here you can see that I may have actually gotten a little bit larger piece than I wanted, because I have to go after that again, and it's actually fractured slightly, and some of those pieces have come up when I didn't want them to. So I'm going to adapt my chop technique in the next section so that I get a smaller piece, which I will not have to chase down. Now again, we're going to rotate the nucleus, this time using the phaconeedle to rotate, and now we're going to take this quarter piece here and break it into 2/8 size pieces by again chopping that, and you can see we're going to get a division there after using high vacuum, and now we just have a little piece that we can easily consume, and that's about the right size here. This is a fairly dense lens, although it does not have a lot of brunescence. It is rather dense, and so it's going to require smaller little pieces, and there you can see I've chopped it again, and now this little piece will have little tendency to fly up into the anterior chamber. It will stay around the phaconeedle, and the pieces will have less tendency to wander off, although as you can see I do have one chip there that's come up, and I'm going to go after that now because I don't want that to hide above the iris or get in the subincisional ciliary sulcus where I won't find it later. So these pieces need to be chased down if they come up. I'm now going to use the penguin chopper tip again to rotate the remaining heminucleus distally, impale that with very high vacuum, moderate amounts of ultrasound, and again chop that up so that I get a piece that I can consume fairly easily. And you can see that there is some tendency for that to fly around, but if I get the pieces just the right size, they won't fly around the anterior chamber, and I'll be able to control them more adequately. So here I'm going to chop that again into yet a smaller piece. And you'll notice the strategy here is to use mechanical forces, that is the very sharp chopper, to break this nucleus up into small pieces, and then use generally high vacuum with just ultrasound power assist as needed to emulsify it. So I'm really just tapping into foot pedal position 3 and using mostly vacuum and my aspiration flow to bring material to the tip. Now only the epinuclear shell remains, and what I'm going to try to do here is to trim the roof and rim of the epinucleus without bringing the floor of the epinucleus into the phaconeedle. And you can see that I need to hold that back with the irrigation stream that's coming out of the irrigating chopper or with the chopper itself to disallow the epinucleus from coming into the tip. The reason for this is that as I trim the rim of the epinucleus, cortical material from behind the epinucleus will have a tendency to come and flow into the phaconeedle. This was described originally in 1992 in the classic article Cortical Cleaving Hydrodissection, published by Howard Fine in the Journal of Cataract and Refractive Surgery. And this technique is as valid today as it was then. In most cases, it obviates the need for irrigation and aspiration as a separate step. And you can see here how virtually all of the cortical material has come out of the eye, especially in the distal bag, and I've just got a few little pieces remaining proximally. So now I'm going to turn that very sharp chop element up out of the way and bring a 0.2 millimeter aspiration tip in with my right hand, never turning off the irrigation so that I maintain a stable anterior chamber throughout, and now I can remove those little pieces of cortex very easily. Again, they have been loosened by cortical cleaving hydrodissection. Now there's a little plaque on the posterior capsule, and I'm going to zoom in closer so that I can see this and gently polish the posterior capsule with this roughened aspiration tip. And this is a very nice technique for cleaning the posterior capsule and will help to prevent the need for a posterior capsulotomy down the road. It's interesting to note that in most of the surveys of retinal detachment in high myopia after cataract surgery, retinal detachments tend to occur following YAG laser capsulotomy. So maintaining the integrity of the posterior capsule is very important, particularly in high myopia, but really in all eyes. And so by cleaning the capsule thoroughly, performing a very careful cortical cleanup, and maintaining a capsular rhexis size smaller than the lens optic, we can ensure a good shrink wrap, induce a posterior capsular bend formation, and inhibit the development of posterior capsular opacification. Now, to insert the implant, I need to create a new incision because I do not have available to me any IOLs which can be placed through an incision of less than 2.2 millimeters. And here, utilizing the unfolder, we're going to place a Technus intraocular lens in the capsular bag, and we can generally deliver the trailing haptic by using the plunger there, as you see. And that will be placed in the bag. And then we can come back now through our incision that we use to place the IOL with a coaxial irrigation aspiration handpiece. We are removing viscoelastic from behind the intraocular lens. If the capsular rhexis is smaller than the lens optic, there is a chance of inducing a capsular block syndrome in the postoperative period. What this means is a myopic shift, shallow chamber, and viscoelastic that is remaining behind the lens optic in the bag, inducing an osmotic effect, and that requires a anterior YAG capsulotomy, so we want to avoid that by removing viscoelastic from the bag. Here we're using a 30 gauge cannula to perform stromal hydration. I perform stromal hydration 100% of the time to ensure self-sealing corneal incisions. This will bring the roof and the floor of the incision together so that the corneal endothelial pump can go to work, inducing a negative turgor pressure within the cornea and maintaining that self-sealing characteristic of the incision. Surprisingly, the main incision, which has seen very little instrumentation but is much larger than the other incisions, actually seals the best. The smaller microincisions, which have been instrumented a bit more, if any, may tend to show some leakage. But here you see there's just a little bit of incisional outflow from that left-handed incision, and we're going to wait for that to cease before completing our case. So we want a completely Seidel negative situation before we conclude. Sometimes this requires a little bit of massage over the incision. Sometimes just a little bit of time will do the trick, or adjusting the intraocular pressure. Here you can see that with just a little bit of time, we've got a Seidel negative case, and we are finished.
This video will demonstrate the injection of a capsular tension ring in a case of compromised zonules. Being demonstrated is the universal injector. The eyelet hook can be seen in an extended and a retracted position. A stabilized 13 millimeter capsular tension ring was utilized in this case. The capsular tension ring container can be used as a platform for loading the ring. A dollop of viscoelastic is placed on the container, and the capsular tension ring is placed in the viscoelastic. This serves to stabilize the ring while the leading eyelet is captured with the injector hook. The capsular tension ring should be easily withdrawn into the injector with no evidence of resistance. The injector is then placed into the anterior chamber, and the capsular tension ring is pushed into the capsular bag. Some displacement of the capsular bag can be seen during this part of the procedure. The trailing eyelet usually pops off the hook with ease, but a second instrument can be used as needed to facilitate this maneuver. This is a case of a routine phacoemulsification with obvious zonular instability. During the initiation of the capsular rhexis, the cystotome produces significant stria. In addition, the nucleus can be seen to wobble slightly. These are clear signs of zonular instability. In addition, during phacoemulsification, the nucleus can be seen pulling to the surgeon's right, with a large gap noted to surgeon's left. This is an indication of either absent or significantly weakened zonules. Phacoemulsification and irrigation and aspiration were gently used to remove the remaining nuclear fragments. At this point, it was determined that a capsular tension ring could be safely inserted. In this case, a Morcher 14C ring was utilized. The capsular tension ring is placed on a small dollop of viscoelastic to allow the eyelets to overhang the well. The injector hook can then easily grasp one eyelet and pull the capsular tension ring into the device. The inserter will then be placed into the anterior chamber, and the capsular tension ring will be injected into the bag. During this maneuver, the anterior capsulorhexis will be noted to displace slightly. This can be slightly unnerving to the novice surgeon, but is typical of capsular tension ring placement. The trailing eyelet usually pops off the injector hook as demonstrated in this case, but occasionally a second instrument must be utilized. As evidenced here, significant increase in stability of the bag is noted after placement of the capsular tension ring. This allowed for easy and safe removal of the remaining cortical material. This case has demonstrated some of the classic findings of zonular instability in a routine phacoemulsification case.
We're going to demonstrate loading AMO's Technis one-piece acrylic IOL. We're going to be using the 1 series cartridge and the Emerald series AR injector system. It has a series of grooves in the plunger, which causes a advance and retract cycle in the plunger tip, while the implanter just rotates forward in a twist motion. So taking the 1 series cartridge, the ZCB00 lens can be lifted from its packaging materials and placed next to the cartridge itself. The barrel and the channels of the cartridge are filled with viscoelastic. There is no need to place OVD on top of the optic or the haptics themselves. The lens is then lifted and placed into the cartridge channel immediately adjacent to the picture of the lens on the cartridge wing. The far side, or the distal side of the lens, can be held down gently as the wing of the cartridge is lifted upwards, holding both edges of the optic underneath the channel ridges. The leading haptic can be folded back onto the optic itself, lifting the wings of the cartridge slightly to hold it in place. The trailing haptic can be folded upwards as well, forward onto the optic. The whole unit can be held in place as the wings are lifted, closing the cartridge. You want to ensure that the haptics are not caught within the wings themselves. The whole unit is then placed within the tip of the injector. The plunger, with its unique ridges that causes that advance retract motion, is pushed forward, engaging. The plunger is pushed forward, causing that advance retract action, while the implanter is simply rotating forward. Being acrylic, the action is very stiff. Then the lens is delivered into the eye. This is the Emerald series unfolder. It's for AMO's 3-piece acrylics, the ZA9003, AR40E, and XG1. Fill the cartridge, its barrel, and 2 channels with viscoelastic. And dollop in the middle. With a smooth lens loading forceps, you can lift the lens from its packaging and place it in the center of those 2 channels. You want to press down on the sides of the optic, trapping the acrylic half optic underneath the ledges. This lens wants to fold upwards instead of downwards, which is what you want. So you need to press on the center of the optic while lifting the wings of the cartridge to get that to kind of taco or fold downwards instead of upwards. Guide the leading haptic into the barrel of the cartridge and make sure the trailing is out, which it easily does. Fold it and insert it snugly into the injector. Ensure that the trailing haptic is up over the side of the cartridge, of the injector, so that it will not be caught by the plunger. Advance the lens and with a twisting motion. It's a very stiff acrylic lens, so the action is going to be very stiff, both during loading and injection of the lens into the eye. And just stop before the leading haptic exits the tip of the cartridge.
This is the AMO Silver Series unfolder for the Clariflex SA40 Array and Z9002 IOLs. The first step is to place the Teflon tip on the injector rod and ensure that it is secured in place. The cartridge is then removed from the packaging, and the barrel of the cartridge is filled with viscoelastic. The 2 channels on either side of the wings are also filled with viscoelastic, and a small dollop is added on the central ridge. Using a smooth lens loading forceps, the lens is removed from the package. In this case, the lens is inverted upside down, but it will be placed in its proper orientation. And it's transferred to the center of the cartridge, resting on the central ridge. Initially holding the wings of the 2 channels spread wide depress the sides of the optic under the ledges of the two channels, and then bringing the wings partially together. This will hold the lens in place. Place the leading haptic inside the barrel, trapping it in an extended position. And check that the trailing haptic exits the rear of the cartridge. Close the wings of the cartridge and then inspect the leading haptic to ensure that it is in an extended position. Next, insert the cartridge firmly into the injector, assuring that the trailing haptic rests to the side of the injector, out of the way of the plunger. Advance the plunger, moving the lens forward toward the tip of the cartridge, stopping before the leading haptic exits the tip. The action should be very smooth, which is characteristic of foldable silicone intraocular lenses.
This is Alcon's single-piece acrylic loading system. It's a Green Monarch 2, and it uses a C cartridge. There's a little C on the cartridge on one of the trailing pieces, as well as showing a picture of the orientation of the lens. First, fill the cartridge about 2/3 full with viscoelastic of some sort. Put some dots of viscoelastic on the trailing, leading, and optic to help facilitate the unfolding of this lens later when it's in the eye. Lift the lens from its packaging. And using the back end of the cartridge, fold the leading haptic over the optic as it's inserted into the opening of the cartridge. Advance the lens with your smooth forceps until just the trailing haptic sticks out, and then fold that one up over the optic as well, capturing it inside. Advance the lens within the cartridge, trapping those haptics up over the optic. Snap the cartridge into the injector and advance the lens up the cartridge. And then there's a twist action to get it to get right to the tip.
The AMO Technis single-piece acrylic intraocular lens can be easily injected through a 2.7mm incision utilizing the Unfolder Emerald Series AR injection system. Clockwise rotation of the injector handle causes an initial clicking sensation as the patented grooves within the piston alternate an advance and retract motion of the insertion rod. This motion prevents override of the IOL with the injector rod until the IOL is advanced into the injector cartridge, at which time the rod movement becomes a smooth advance motion. The acrylic IOL slowly unfolds within the capsular bag. Placement and centration of the IOL can be accomplished with a Lester hook or the irrigation, and aspiration cannula. In this example, the entire intraocular lens will be injected into the eye using the cartridge injector. The leading haptic of this acrylic resume lens is injected into the capsular bag with the haptic pointed to the left in the proper orientation. The lens is then placed within the capsular bag, and the injector rod is retracted beyond the trailing haptic, and then injected through the opening of the cartridge, placing the trailing haptic within the capsular bag through the anterior capsular rhexis. Supporting the globe with a blunt instrument placed through the paracentesis, the cartridge is inserted through the main incision and the lens is injected into the eye with the leading haptic in the proper orientation directed to the left. The optic is then unfolded within the capsular bag and the injector rod and cartridge are removed from the globe. The lens is dialed into the capsular bag by placing a Lester hook at the junction of the optic and the trailing haptic, and with a slight downward pressure, a clockwise rotation of the haptic will place the trailing haptic through the anterior rhexis, and the entire lens will be in the capsular bag. This is a patient who developed a capsular tear early in her surgical procedure and eventually required implantation of a sulcus IOL. A bimanual microincision phacoemulsification technique is being utilized in this patient. The first chop was made without any problem, and it is most likely during this second chop that a tear in the posterior capsule was created. You can see with removal of this quadrant of endonucleus that there is an enhanced red reflex corresponding to an opening in the posterior epinucleus and most likely the posterior capsule. At the time of the procedure, there was no difficulty noted. However, during trimming of the epinucleus, it became apparent that there was a discontinuity in the posterior capsule. It is at this part of the procedure where most novice surgeons make the same mistake. We remove the instruments from the eye and look down in disbelief as the vitreous comes forward through the opening in the posterior capsule and pours out of our incisions. The secret for dealing with a torn posterior capsule, whether proceeding with a bimanual or a coaxial technique, is to keep the infusion in the eye and keep the eye pressurized. Under most circumstances, a pressurized eye will keep the vitreous from coming forward through the opening in the posterior capsule. In this case, as much epinuclear material as possible is removed with the bare phaco needle, and then a dispersive viscoelastic is injected into the capsular bag as the irrigator is left in the eye. Once the posterior capsule is tamponaded with the viscoelastic and the eye is pressurized, the irrigator can then be removed safely with less likelihood of prolapse of the vitreous into the anterior chamber. A side irrigating cannula is going to be placed through the right hand incision, and then the aspirating cannula is placed through the left hand incision, and using this bimanual technique, the cortex is then removed, starting with the cortex most distal from the tear in the upper left quadrant. If vitreous presented, the irrigator would be left in the eye and a bare vitrectomy would be placed through the left-hand incision, followed by tamponade of the posterior capsule with additional viscoelastic. But in this case, all of the lens material was removed without vitreous loss. Again, the irrigator is left in the eye and additional viscoelastic is placed in the capsular bag to tamponade the large tear in the posterior capsule. A small quantity of viscoelastic is placed between the anterior capsule and the iris to facilitate sulcus implantation. The incision is widened to approximately 3 millimeters so that no stress is placed on the globe during insertion of the cartridge injector. The secret for implanting a lens in the sulcus using a cartridge injector is to inject the lens with the leading haptic in the proper orientation directed to the left and place the leading haptic underneath the iris in front of the anterior capsule rhexis, and as the lens optic is unfolding, place the optic under the iris so that it does not flip in the upside down configuration. Once the optic is unfolded, the trailing haptic can then be dialed safely into the sulcus between the anterior capsule and the iris. The optic is then centered and prolapsed through the anterior capsule rhexis using the Lester hook to depress each edge of the optic posteriorly. When the optic is captured through the anterior capsule rhexis, aspiration of residual viscoelastic material can then be performed safely using the INA handpiece with less likelihood of vitreous coming into the anterior chamber. This is followed by injection of myocol and then stromal hydration to facilitate self-sealing of the clear corneal incision. This is another example of a torn posterior capsule that was not appreciated until after the epinuclear material was removed from the eye. The irrigating chopper is left in the anterior chamber, and as much epinuclear material as possible is removed with the bare phacoemulsification needle. A dispersive viscoelastic is then injected into the capsular bag to tamponade the tear in the posterior capsule, and the irrigating chopper is removed from the globe. Bimanual irrigation and aspiration is then utilized to remove the remaining cortical material. By keeping the eye inflated throughout the entire procedure, the vitreous remains in the posterior chamber. Viscoelastic is placed between the anterior capsule and the iris, distal to the incision, and in the subincisional area to aid in implantation of the foldable IOL into the ciliary sulcus. An incision slightly larger than usual is made to avoid excessive pressure on the globe, which should keep the vitreous from prolapsing into the anterior chamber. The lens is injected with the leading haptic directed to the left, and as the optic unfolds, it is pushed under the iris so that it will remain in the proper orientation. The trailing haptic is then easily dialed into the ciliary sulcus using a Lester hook. The optic is prolapsed through the anterior capsule rhexis, and residual viscoelastic is removed using the INA handpiece.